Uh, Hello, hi, welcome back. I think you're able to hear and see me. No problem, right? Cool. Okay. I finished some of my works that is left. That was left actually. So I finished my today's work, so I think we can take another 2 hours of session. Must be fine. I think where we'll be able to complete the AK and CKD part, and maybe, if possible, the transplant section also. So AK, we have almost completed, I think. So we have talked about the special causes also. I think we have only few causes now. Maybe one is the cardiorenal syndrome, which I want to talk about. Hepatorenal syndrome second. Then probably we can talk about the post-renal AK, that is obstructive causes. As far as other special causes are concerned, hepatorenal syndrome, HRS. Hepatorenal syndrome is basically a problem of exclusion, which means you cannot diagnose hepatorenal syndrome through some criteria. It's just a diagnosis of exclusion. First thing you need to know about that. In any patient who's having a cirrhosis, if a patient comes with AKI, the first thing you should not think about is hepatorenal syndrome, because there are multiple other causes of renal failure in a patient with cirrhosis. So, in fact, the most common cause is actually sepsis, not hepatorenal syndrome. It's actually a diagnosis of exclusion. That's what you need to think about. The reason for hepatorenal syndrome is quite simple. So you have the liver where your portal circulation reaches basically. So probably this you can take it as the intestinal mesenteric circulation. Mesenteric circulation becomes the portal circulation. This portal circulation, after getting into the liver, they enter the hepatic veins, which is going to enter the IVC. This IVC is going to enter the heart compartment. Maybe I can draw something a little different. So we can draw the heart where the blood is going to reach, and from there you're going to get the aorta, and from the aorta you are going to get perfusion of a lot of organs, a lot of different organs. Maybe you can draw maybe the kidney here. Why kidney is actually quite bad. Okay, so we can draw the kidney maybe. Fine. So what happens here is the fact that in a patient with cirrhosis, you're going to have severe resistance at the sinusoid level. We'll be discussing more about that in hepatology section. Definitely will be starting tomorrow, hepatology section. So that time you'll be understanding it much better. So why there is an obstruction, not obstruction really, there will be something called a sinusoidal resistance or sinusoidal hypertension. So because the blood finds a hard way to move out of the liver, there will be a lot of blood that accumulates within the portal circulation, and this is the reason for elevated portal pressures, which is the problem that results in development of your varices, and at the same time this is also important for development of ascites and so much other problems. The amount of blood that enters the systemic circulation is basically quite low, and because there is so much of blood that is present in the mesenteric circulation, the mesenteric vasculature will go for some adaptation. Like, for example, they tend to produce excessive nitric oxide, which means they tend to reduce the resistance, and because there will be something called as Planck vasodilation. And this happens as a result of adaptation of this excess blood that is present in the mesenteric veins and mesenteric vasculature. And this low resistance that is created in the mesenteric vasculature is actually pushing more and more blood into the mesenteric vasculature because they have low resistance, but effectively it is not moving through the liver and coming out. So what really happens is the heart also tries to adapt to that by pumping out more blood. But even though they pump out more blood, most of the blood is actually getting wasted by entering into the mesenteric circulation rather than perfusing other organs. So other organs like probably kidneys receive low perfusion, and this low perfusion to the kidneys is the main reason why you are going to result in a pre-renal type of AK, and this pre-renal type of AK is what we refer to as hepatorenal syndrome, which means hepatorenal syndrome is typically and purely a problem due to cirrhosis and portal hypertension causing low perfusion to the kidneys, thereby resulting in HRS. If you ask the cardiac output, as far as the cardiac output in heart, the cardiac output may be actually normal or even increased in patients with cirrhosis. The reason is because even though there is a lesser blood that reaches the heart tries to compensate by actually pumping out more because of the higher grade of sympathetic activation in these patients. There might be actually pumping more cardiac output, but whatever the cardiac output that is coming is actually entering the mesenteric circulature with poor perfusion to the other organs. One of the main organs that suffer is basically the kidneys. And at the same time, it's been suggested that the kidneys are actually producing lower nitric oxide. The renal vasculature is actually producing lower nitric oxide. That is also one probable reason why they go for vasoconstriction, and that also could be one of the main reason why you can get low perfusion. Because of that, you can result in a pre-renal decay and hepatorenal syndrome. So what is hepatorenal syndrome? First of all, whenever a patient with cirrhosis, first let us understand how you diagnose. First of all, a patient with cirrhosis and portal hypertension comes with probable rise in serum creatinine. So don't jump into conclusion that this patient is having hepatorenal syndrome. The first thing I need to do is I need to rule out hypovolemic state, because many of the cirrhosis patients will be having some element of hypovolemia because of the vigorous use of diuretics most of the time, because most of these patients will be on higher dose of Lasix and higher dose of spironolactone. So first try to stop diuretics. That's what I'm trying to do, number one. And second, once I stop diuretics, I need to give a volume replacement. But in cirrhosis patients, I don't want to give volume replacement in the form of sodium chloride solutions, because sodium excess is the reason for why they develop volume overload state in ascites. One of the reasons, edema, volume overload and all. But I don't want to use a sodium related fluid, but instead I want to use a non-sodium containing volume replacement strategies like albumin. That's what I'm going to use. Give albumin maybe 1.5 to 2 liters over a period of 48 hours. That's what I'm going to give. So once I've given sufficient amount of albumin, and this albumin should be salt free. Typically we use a higher concentration of albumin, like 20% albumin, which is actually having lesser salt compared to the routine 5% albumin. So I'll be using a higher concentration of albumin with lesser salt, so that the patient doesn't go for more volume overload state. So I need to give a volume replacement, so thereby preventing the wrong diagnosis of hypovolemia related renal failure. So then I make sure that patient is not having any nephrotoxic drugs. So make sure the patient is not on any nephrotoxic drugs. And number 4, I should also make sure that the patient is not having any kind of sepsis, because presence of sepsis also can result in acute kidney injury. And in fact, it's one of the most common cause of why these patients can develop acute kidney injury. So sepsis is quite common in patients with end-stage cirrhosis and portal hypertension because of spontaneous bacterial peritonitis, which is a very common entity in these patients. So once I have did all these things, I have did the basic workup for 48 hours. I have done all these things. Even after 48 hours, if the AK is not resolving, or if it is worsening, the creatinine is becoming 2.4, 2.5, 3, 4, like that. So now my probable diagnosis is hepatorenal syndrome after I exclude all the other causes. So it's basically a diagnosis of exclusion. That's what you need to know about. Don't straight away jump into the conclusion that this patient is having HRS. So once I make a diagnosis of HRS, I need to treat. So the standard treatment is basically the first line treatment that I start with is basically terlipressin with albumin. So I give more albumin replacement along with terlipressin. This is what I'm going to use. What terlipressin does is, terlipressin is a splanchnic vasoconstrictor. In fact, it's a selective splanchnic vasoconstrictor. So I can block the blood that is moving into the splanchnic circulation, so that I can probably increase the perfusion to the kidneys, because I'm diverting the blood to another area. So that's what terlipressin is going to do. It's a splanchnic vasoconstrictor. It's going to increase the resistance in the splanchnic vasculature. And at the same time, albumin is used for replacing the volume, because you need a little bit more volume to perfuse the kidney. So this is what I'm going to use. Suppose if the patient is refractory to my first line treatment, then the best option is to go for TIPS. That is transjugular intrahepatic portosystemic shunt. So that's what I can use if suppose the patient is refractory. But the overall best treatment for any kind of cirrhosis related problem is liver transplant only. Even though transplant is the best treatment, it's not available for many patients. But TIPS is there is something intermediate, like you can they can act as a bridge between a transplant and a medical management. So But the best treatment for any cirrhosis-related complication, which is refractory, is of course going to be liver transplant only. There's no doubt. What TIPS does is very simple. TIPS bridges the portal vein with a hepatic vein using a stent or a conduit. We use a PTFE stent. So we actually bridge the portal vein with the hepatic vein, one of the branch of portal vein with one of the branches of the hepatic vein. That's what we are going to do by giving TIPS, so that now the blood doesn't have any hard time at all. It easily moves through this conduit into the circulation, into the systemic circulation, so that your portal pressure will reduce. There will be a significant reduction in the portal pressure. Once you reduce the portal pressure, this nitric oxide related imbalances will settle off, and of course you will result in improvement in the varices, ascites, and even hepatorenal syndrome for that matters. But one thing actually will not improve with TIPS or any portosystemic shunt, that is liver failure itself. Because if the liver is dysfunctional, you will result in encephalopathy, and you're going to result in coagulopathy. And this kind of coagulopathy, encephalopathy and all will not reverse as long as you do a liver transplantation. So in fact, TIPS is having a higher risk of encephalopathy because the blood is actually directly shunted from the dirty blood from the portal circulation is directly shunted to the systemic circulation. So TIPS is in fact having a higher risk of producing hepatic encephalopathy. That's why hepatic encephalopathy is actually quite a contraindication for doing TIPS. So don't do it if the patient is having a significant hepatic encephalopathy. So liver failure related problems will not resolve with TIPS, but portal pressure related problems will definitely resolve with TIPS. There are many portal pressure related problems. The three classic problems that we face is varices, ascites, and hepatorenal syndrome. All these things are portal pressure related problems that will basically respond to TIPS. But failure related problems, like where the liver cell function is affected, like coagulation protein production and albumin production, and probably your encephalopathy, purifying the blood from ammonia. So all these functions are basically carried by the liver cell. Just by bypassing through TIPS is not going to affect all this, and in fact that problems will not be settled with TIPS. Anyways, you know the diagnosis of hepatorenal syndrome and how to treat an hepatorenal syndrome. This must be much simpler. So remember, in hepatorenal syndrome, the urine will always be prerenal in picture. There will be extremely low urinary sodium most of the times, and the FeNA will be extremely low as well most of the time because it's so prerenal, and it will always be prerenal. Even if the patient is having sepsis-related acute tubular necrosis, if it's a patient with cirrhosis, I always expect a low urinary sodium because HRS is so prerenal, so prerenal. It will always remain prerenal despite the fact that the patient might be having an underlying acute tubular necrosis due to some other cause as well. Doesn't matter. So that's why FeNA usually less than 1% is the usual traditional understanding as far as your prerenal failure is concerned. But in HRS patients, usually FeNA will be as low as 0.3%. FeNA will be as low as 0.3. Very, very low FeNA. As little as 0.3. And in some patients with severe HRS, the FeNA can be less than 0.1 in fact. In fact, any patient with the FeNA of more than 0.3 in patients with the cirrhosis, I'll take it as an underlying acute tubular necrosis, which means it's that significant. So FeNA will always be less than 1%. In fact, it will be less than 0.3. Any FeNA more than 0.3 in patient with cirrhosis should give rise to a strong suspicion of an underlying acute tubular necrosis because they'll always be having a severe prerenal kind of a picture only. Then we have something called a cardiorenal syndrome. So cardiorenal syndrome itself has many different types of picture in reality. As far as cardiorenal syndrome is concerned, you have 5 major types of cardiorenal syndrome. You all will be knowing that. So you have a type 1 cardiorenal syndrome. This is called as acute cardiorenal syndrome. Here the problem is acute decompensated heart failure or acute worsening of heart failure. We call it as ADHF, resulting in acute kidney injury. So this is what we refer to as a type 1 CRS, cardiorenal syndrome. And we have something called a type 2 cardiorenal syndrome, also called as chronic cardiorenal syndrome. Type 2 cardiorenal syndrome, where you have a chronic heart failure resulting in a kidney injury. Kidney injury, it can be acute or chronic. That's called a type 2 cardiorenal syndrome. And type 3 is also called as acute renocardiac syndrome. Like for example, an acute kidney injury can result in changes in the cardiac function. So it can result in heart failure. So that is what we refer to as a type 3, or maybe do myocardial infarction or something. So any acute kidney injury causing a cardiac problem is type 3 cardiorenal syndrome. In fact, type 3 is not called as cardiorenal syndrome, it's called as a renal-cardiac syndrome because the problem in the kidney then progress to the heart. So type 4 is CKD causing cardiac issues like heart failure or myocardial infarction. This is type 4 chronic renal-cardiac syndrome. And type 5. So it's not the problem of the kidney or it's not the problem of heart failure. It's some systemic condition that is causing injury to both kidney as well as the heart. It is some systemic condition that is causing problems in both kidney as well as the heart. For example, the best example probably I will think it's probably a Chukstad syndrome where it affects the myocardium causing myocarditis and it can at the same time cause your renal failure as well, RPGN. So systemic condition producing kidney and heart involvement simultaneously. This is what we call as a type 5 cardiorenal syndrome. In that the usual cardiorenal syndrome that we encounter is the type 1 cardiorenal syndrome where your ADHF is going to result in acute kidney injury. That's quite common in patients with cardiorenal syndrome. Please trust me, any condition, irrespective of the nature of the condition or irrespective of the status, especially if it happens in in-hospital patients or in ICU setting, if you have an AK, if you have an associated AK, it could be a stroke or it could be a cardiac failure or it could be any other condition. If you have an associated AK, this condition will have higher mortality. So this is very important, which means AK is a independent predictor of mortality in hospitalized patients, which means any hospitalized patient due to any condition is getting admitted, develops acute kidney injury, that itself increases the mortality, which means that condition will have higher mortality. Any condition, does not matter, stroke, heart failure, ARDS, or a pneumonia, doesn't matter at all. Go to any scoring system. For example, go to a what is that GI bleeding scoring system. Go to yes, it's like troponin elevation. Go to a what is that heart failure scoring system. So any scoring system if you take, so if there is a higher creatinine, you always, even SOFA score, if you go to the that original SOFA score, you have creatinine. So any condition that has high creatinine, you have a high mortality. Especially if you have a AK in hospital settings or ICU settings, you have a high mortality, which means AK is an independent predictor of mortality in hospitalized patients. That's all. So ADHF is not an exception. That's what I'm trying to do. Any ADHF patient who's having an acute kidney injury, they have a higher mortality, which means, there is a trial which says approximately there is a 7 to 10% increased mortality with every 10 ml per minute per 1.73 meter square fall in the GFR. So in patients with ADHF, for every 10 ml per minute fall in the GFR, you will be having 7 to 10% increase in mortality. It's a very common entity in ADHF seeing a acute kidney injury. Nevertheless, how will you treat these patients? Because this is a very common subset of patients you're going to encounter in clinical practice. How you're going to treat these patients? The treatment of these patients mostly involve loop diuretics. You have to give vigorous diuresis in these patients. There are a lot of reasons why these patients develop AK. So as I told you, if you take, this is the kidney. Let us assume this is the renal artery. Of course, when it comes out as renal vein, the blood will be purified. You'll have a renal vein here, and you're going to produce a urine output from the kidney, which is excreted. So, and these renal veins are going to join the IVC. And this IVC is going to enter the right heart, basically. Going to go into the heart. We know that. And from the heart, you're going to get back, like this. Maybe I can write here. From the heart, you will be coming back to the renal artery. So we don't want that. So let us, for simplicity purpose, let us avoid that. And one of the main reason why the kidneys go for dysfunction is the fact that increased intraglomerular pressure and increased intra-kidney pressure. That's the reason. So how it happens is because whenever there is a heart failure, there will be passive congestion. The forward movement will be low. Because of the passive congestion, there will be severe congestion under the kidneys. There will be more congestion in the renal veins and there will be more congestion in the kidneys. So because of severe congestion, your forward movement will be very slow. apart from the fact that they will have a low cardiac output where the forward blood flow will be very low. I'm not talking about that, but one of the main reason is actually this increased congestion is one of the main reason in heart failure, especially ADHF patients, why you have a low renal output, low urine output, because of the forward movement into the kidneys is very difficult because of severely congested kidneys and the renal veins and the renal vasculature. Your urine output will actually fall. So you have to lift this urine output first of all by giving a vigorous diuresis, especially loop diuretics are extremely important in this scenario. So once you give a vigorous diuresis, especially we give a IV loop diuretics, you give bolus, infusion, doesn't matter. You need a very high dose of loop diuretics. So when you give high dose of loop diuretics, you increase the urine output. Once you increase the urine output, this congestion will resolve to a large extent. Once the congestion resolves, now the forward flow will become much easier. At the same time, you will be using some inotropic drugs that will help the heart to pump out excess blood. So that can also improve the cardiac output to a large extent. So, of course, I believe that loop diuresis is one of the mainstay, but I don't know why many people think like in a heart failure, if the patient is having high creatinine, I should not use diuretics. I use diuretics left and right. In fact, the ceiling dose in heart failure is actually much higher compared to the ceiling dose that we use in routine patients. So you can use higher dose of loop diuretics, not a problem. They don't really respond to the dose of 5-10 milligram. Usually you have to give bolus of 40, 60, sometimes 80 milligram. So especially if the patient is not hypotensive, then I can give even more higher doses also. That really works in patients with ADHF. There are many other drugs that you can use, like for example, Nesiritide is there. Then we have dialysis is there. We can use, but remember, dialysis is something that doesn't work here. Unless and until there are some compelling indication to dialysis, which I'll tell you in some time, but dialysis usually does not work that much in ADHF causing acute kidney injury. It's always the loop diuretics that does the wonder, and the trick is actually using a higher dose of loop diuretics. That's all. This is cardiorenal syndrome. So you have a HRS, you have a CRS. I think the only type of AK that is left is this post-renal AK, which we have not studied at all. Post-renal AK. As far as the post-renal AK is concerned, it is typically due to obstruction. Some form of obstruction will be there. It is obstructive uropathy. So that is the usual reason why you develop a post-renal AK in the first place. The cause could be anything. So the cause could be either in the bladder or above the bladder. So that's how I generally split. So either the cause could be in the bladder and below the bladder or above the bladder, because that has some diagnostic significance above the bladder as well. Suppose the patient is having causes in the bladder, means it could be stones, which are very rare. Actually, bladder stones are not very common. And second thing, that is bladder cancer, very, very rare. Usually bladder cancer can produce dysuria, but that too at late stages, but they don't really produce, like obstruction and post-renal AK. But the usual causes because of what you get this post-renal AK is the neurogenic bladder. This is the usual cause that we expect, because in a neurogenic bladder, there are multiple reasons why you should develop AK, because the patient will not be having a proper sensation of bladder getting emptied or bladder getting retained also. So there will be massive accumulation of urine over a period of time where the patient will not be aware of. And at the same time, that kind of massive accumulation can easily lead on to AK because of increased intraglommerular pressure. So that's why neurogenic bladder is quite common in our setting, where we see a lot of patients coming in the post-renal AK. And apart from that, I can go for other conditions like bladder and neck obstruction. As far as bladder and neck obstruction is concerned, I'll be thinking about only two things, that BPH, benign prostatic hyperplasia, and probably even prostate cancer. But I feel like BPH and prostate cancer generally is not a cause of post-renal AK again, because patient will have that sensation. Once the bladder gets filled, they'll complain of pain and they will come back to the hospital within 1 or 2 days maybe. So the sensation will still be there. So it's okay. Even if the bladder gets filled, the patient will come back faster. So going to a level of AK is actually quite rare with benign prostatic hyperplasia and prostate cancer. But whenever the patient with BPH comes with elevated creatinine, always think about underlying infection, because there could be severe urinary tract infection that produces sepsis and that can cause AK. So I always think about that. Whenever the neurogenic bladder, it could be a true cause of post-renal AK. And there are many anticholinergic medications. anticholinergic drugs, because especially old age people will be on a lot of anticholinergic drugs. That's why I mean, like for example, amitriptyline we give because of there are other issues like overactive bladder and all these things. We might give amitriptyline, or patient might be taking trihexyphenidyl for Parkinson disease. So many other anticholinergic drugs we might be giving in old age people, especially if they have BPH and they are giving anticholinergic drugs. There is an added problem that already there is a bladder neck obstruction. You're giving anticholinergic drug that relaxes the bladder, so the risk of developing a like a urinary retention and postrenal AK is quite higher. So these are some examples, but I always think about postrenal AK is neurogenic bladder. That's what my mind is fixed at. I never seen much other cases that causes problems in the bladder. Or it can, below the bladder, it can happen with urethral problems, urethral issues like urethral stenosis or urethral stones, and these are very easy to pick up, not a big deal at all. And at the same time, if you go for causes above the bladder, usually you think about uretral causes, ureteric problems. As far as the uretral causes are concerned, I generally think about stones, but stones happening bilaterally causing bilateral ureter obstruction and a postrenal AK is quite rare. Remember, unilateral stones usually will not result in AK. They will result only in severe pain. They will not result in AK. The reason, because if you have a unilateral stone, even though one kidney is completely non-functional, the other kidney will still be functional. So, of course, we can survive with one kidney, isn't it? So, it's enough. So, usually you should not get an AK. But whenever a unilateral stone producing an AK, always again suspect a pyelonephritis. Because of urinary stasis, they can go for pyelonephritis. And that pyelonephritis, because of sepsis, can cause high creatinine. So whenever unilateral stone causing AK, always think about an associated infection to pyelonephritis. If stone alone, one side causing AK is actually very rare. You don't really get it. Or unilateral stones can produce AK in one condition where you have a single kidney. So if you don't have two kidneys, there are some people who are born with a single kidney or only one functioning kidney will be there, or who have been donated a kidney. In those patients, even unilateral stones can produce AK because they have only one kidney. But nevertheless, bilateral stones alone as a cause of AK, unilateral stones alone as a cause of AK in a patient who is having two kidneys is extremely unlikely. Point number one. And second is malignancy, malignant deposits. Malignant deposits causing severe retroperitoneal lymphadenopathy. Severe retroperitoneal lymphadenopathy, and this is extremely true in patients with cervix cancer. And this is a very common question in exam. Any cervical cancer patient, if they come with anuria or if they come with AKI, the first thing I'll be thinking about is malignant deposit in the retroperitoneal lymph nodes, obstructing the ureter, compressing on the ureter, causing AKI. In fact, the most common cause of death in patients with cervical cancer is AKI, and the most common cause of AKI that happens in patients with cervical cancer is this this thing only, postrenal AK only. And then you can get with something called retroperitoneal fibrosis, which is very, very important. So if it happens idiopathically, it's called Ormond's disease, but idiopathic retroperitoneal fibrosis is rare. There should be usually some underlying condition that may be there, which can actually, in the fibrosis, the ureters can be trapped and they can go for bilateral H1 and they can go for problems. So that's what is going to happen, retroperitoneal fibrosis. And you can get with ureteric strictures that happens after a surgery, maybe sometimes. Strictures in the ureter that can happen after gynecological surgery, or that can happen after hysterectomy very specifically, or ureteric injury. Again, hysterectomy is one of the very common, common surgeries where after ureteric injury can be expected, if it's done by a less skilled surgeon, of course. And next, you can get in patients with nephrolithiasis, but again, very rare, unless and until it's a bilateral nephrolithiasis, and it's actually a calicial stone. It's very big, like struvite stones. It's unlikely to cause a problem. But as far as I know, the most significant thing here I feel is the malignant deposits and probably post-operative injury and retroperitoneal fibrosis. These are three things where I believe it's a true postrenal AK. How can you understand this postrenal AK causes based on ultrasound? Ultrasound is one of the first line investigations you do for any acute kidney injury. In fact, any AKA patient, next step is you do an ultrasound after knowing the creatinine is very high. The reason is very simple, because you need to rule out two things. One is obstructive causes. That's the first thing you have to rule out. Second thing, you need to find out other causes. Is there any pyelonephritis, perinephric collection? See the size of the kidneys. So a lot of things you can do in ultrasound, but one of the main reasons why you do ultrasound AK is to rule out obstructive causes. As far as ultrasound is concerned, in a bladder and below the bladder causes, there will be increased post-viral residual urine. That's the basic point that you need to know. But whereas in a patient who's having causes above the bladder, they'll be having a normal post-viral residual urine usually. And both these patients may have a bilateral hydrohydronephrosis. Remember, they should have a bilateral hydrohydronephrosis or a unilateral hydrohydronephrosis in a single kidney patient to tell that the patient is having a post-renal AK. And usually, normal post-viral residual urine is 50 to 100 ml. There's a normal post-viral residual urine. Suppose if the patient is a younger patient, age less than 60, I can take 50 as a cutoff. If the patient's age is more than 60, 65, then up to 100 ml is okay. But usually, AK will not result unless and until your post-viral residual urine is more than half to 1 liter. So only in that setting you will result in AK. Otherwise, it will not be that common. So that's why post-renal AK is a tricky situation. Most of the time there will be associated infection or some other cause. But a true post-renal AK means you should have some, basic common sense to diagnose a post-renal AK. Fine. That's why the treatment is also quite simple. As far as the treatment is concerned, in patients with causes that are present in the bladder or below the bladder, I just need a Foley's most of the time. That itself is enough. Or I might need an SPC, suprapubic catheterization. More than enough, isn't it? So just you need to drain the bladder, that's all. So you can do by using Foley's or SPC. That's more than enough as a temporary measure. Of course, you have to treat the underlying cause, but I think this must be more than enough, at least to relieve the AK. As far as these patients who are having above the bladder causes, typically I need to put an ureteric stent and relieve the obstruction from the ureter, which is famously referred to as something called a double J stenting. So typically I need to do a ureteric stenting, or I need to do a PCNL rarely. PCNL, that is called percutaneous nephrolithotomy, if the cause is in the kidney causing nephrolithiasis. So typically I'll go for ureteric stenting only as a temporary measure where I can actually drain the urine from the obstructed area so that the kidney function will return back to normal. If you ask about how the patient will behave, most of the times post-renal AK patients, if it's severe, they can come with absolute anuria. They can come with anuria, really speaking. Yes, even a simple BPH can cause complete anuria. And many times, clinical evidence of patients who are having bladder or bladder neck problems will be having a palpable bladder most of the times. Most of the time, they'll be having a palpable bladder. But most of the times, clinically, they will be having impalpable bladder. And especially patients who are conscious, especially patients like BPH, they might come with complete anuria. And they might be having bladder area tenderness also. When you press, because the bladder is so huge, unless until patient doesn't have neurogenic bladder, when you press for the bladder, they will wince with pain. So I have seen patients with complete anuria, 0 ml urine output for the last 1 day, because it's a complete obstruction. So they cannot pass unless and until you put the Foley's. The moment you put the Foley's, like 1000 ml or 1500, sometimes even it's in 2000 ml of urine rushing out through the Foley's. So always that's really, really important. So in exam, usual question that you will get is a 77-year-old man. I'm telling age, for example, 77-year-old male patient coming with complete anuria, seeing a creatinine of 6.4 milligrams per deciliter, and otherwise he is fine. So they will ask you what is the next step you need to do. So you are going to answer. 77-year-old man, complete anuria, 6.4 serum creatinine. So what is the next step? No, that's the difference between practice and that's the difference between your theory. Yes, here I put a Foley's. That's what I'm going to do. That's first thing. So an elderly man always has a risk of like BPH and all the other problems causing urinary retention. Neurogenic bladder is also higher in this age group. So always go for Foley's in this situation. So Foley's helps in multiple ways. So I'll have a urinary collection. So later on, I can send for urine analysis, which is very, very important because this patient is having anuria. I need some amount of urine at least to maybe to analyze what's happening. I need to look for crystals. I need to look for the sediments, and something is needed. So this Foley's will be helpful in so many situations. So if Foley's is not passed, or if Foley's is having a problem, so then probably, then I can do an ultrasound. But anyway, I will do an ultrasound. I'm not telling I won't do an ultrasound. But in this situation, Foley's is going to be the key. So the next step is going to be insertion of Foley's. Clear. So these kind of questions are extremely common. I mean, there's nothing, you don't need reference for this. Students always ask for reference for these kind of questions. Why you really need reference for these kind of questions? It's just straightforward and what you perform in the wards. That's all. A short note on something called retroperitoneal fibrosis. Retroperitoneal fibrosis basically can be idiopathic. It's a primary disease, idiopathic, or it can be due to some underlying problem, secondary. As far as primary is concerned, typically it's called as Ormond's disease. It's an idiopathic retroperitoneal fibrosis. As far as secondary is concerned, it can be due to atherosclerosis, especially AAA, abdominal aortic aneurysm. In exam, whenever a patient comes with back pain and AKI and having a abdominal aortic aneurysm is equal to retroperitoneal fibrosis. This triad usually will be given in exam. Patient having a history of AAA, or just they can give old age also. If they want to be a little cruel, they will just give old age patient coming with back pain and history of AK. I mean, patients with acute kidney injury. No bladder. Of course, retroperitoneal fibrosis will not cause any palpable bladder because it actually is a problem that affects the ureters, not the bladder. So they might not have a palpable bladder. So always think about, this retroperitoneal fibrosis. It can be due to drug-induced causes. Drugs can produce retroperitoneal fibrosis as well. Like for example, the most important drugs are ergot compounds like methysergide, serotonergic drugs like methysergide, ergot compounds. Then to small extent, beta blockers can cause, hydralazine can cause, but these are rare. But in exam, the most important will be this ergot and methysergide. So these are the compounds that can cause retroperitoneal fibrosis if it's used for a longer time. So or if the patient is having retroperitoneal hemorrhage, over time they can go for fibrosis or history of trauma in the retroperitoneal area. Trauma in the retroperitoneal region. So this can be a blunt trauma, road traffic accident. I mean, it's not renal tubular acidosis. For the first time, I'm writing RTS road traffic accident. It could be due to a road traffic accident, or probably it could be due to a surgery, prior renal surgery. For example, patient has gone for a unilateral nephrectomy, and post-nephrectomy, if the surgery is not very clean and if there's a lot of retroperitoneal trauma that happened during the surgery, then the patient can go for retroperitoneal fibrosis. To some extent, asbestosis is also a risk factor, but nevertheless, only one cause if you want to remember, atherosclerosis, and two more causes you want to remember, this drugs, ergot and methysergide. I don't think apart from that you need to remember anything else. These are two most important causes. And many times, I don't know why they ask that question, many times they might be ANA positive, especially these AAA patients. They might have ANA positivity also. That's a very common question. We don't know why the ANA is there because a lot of postulates are there. But many of the times, AAA related retroperitoneal fibrosis patients may have antinuclear antibody positivity. And as far as clinical features of retroperitoneal fibrosis is concerned, most common symptom will be the back pain plus or minus abdominal pain. That's how they're going to come with. And most of their problems will be non-specific. And patients will be having bilateral HUN, bilateral hydronephrosis on ultrasound, but a normal post-viral residual urine. And other non-specific symptoms that the patient might be having is lower limb claudication. That is because of compression of other arteries like aorta, and it's applied to the lower limbs. And they can develop a DVT because even the veins are compressed, so that there will be stasis of blood in the lower limbs, causing a deep vein thrombus, and they can result in hypertension because of multiple other causes. So these are the usual clinical features, but always think about a back pain patient with a back pain coming with bilateral HUN. Think about a retroperitoneal fibrosis as a very important cause. Remember, you need a biopsy for sure. So because this retroperitoneal fibrosis looks like as if it's a tumor, sometimes it could be IgG4 related disease coming like a tumor that can also cause retroperitoneal fibrosis. So you always need a biopsy. There's no doubt about that. You have to prove that it's only fibrous and it's not a tumor. And most of the time it comes as a mask-like lesion. So you need to rule out a tumor there. So do a biopsy. And as far as treatment is concerned, in the transient phase, you can put a double J stenting, but it's really difficult to put a double J stenting in the presence of RPF, but experienced urologists do pretty easily. So put a DJ stenting first, drain the urine, that's more important. If you cannot put a DJ stent, at least drain the urine by doing a PCNL. So percutaneous nephrostomy can be done and somehow you drain the urine. That's the first step. Plus, you have to start with the definitive management. Definitive management, you can give steroids if you don't have any underlying cause. Second, definitive management is ureterolysis. You can do a surgery called as ureterolysis where you can remove the ureter from the fibrotic segment. So you can separate the ureter from that. So that's what we refer to as a ureterolysis most of the times. Clear? So usually in exam, this is the question. AAA, back pain, AKA, and ultrasound showing bilateral H1. It is retroperitoneal fibrosis unless proved otherwise. That's all. So I think we have discussed in detail about the causes of acute kidney injury already. Now it's better that we move to the indications for urgent dialysis in a patient with AK. Urgent dialysis in patients with AK. So what are the indications for urgent dialysis in patients with AK? So usually vascular access in patients with urgent dialysis usually will be the IJV. Very commonly we are going to use the right internal jugular vein. That's what is going to be very commonly used. So suppose if you cannot use the right IJV, then you can go for the femoral access. But other vascular access are remote. For example, left IJV I generally don't prefer because it's not very good. The catheter will kink very easily, and subclavian, no. Usually I don't use subclavian, and no nephrology use subclavian. And whenever I work in ICU, nephrologist usually tells they do not use subclavian. Subclavian veins are actually more prone for going for stenosis compared to IJV. So we don't really use subclavian. Go for either right IJV or go for femoral. Femoral is also good, not a problem. So better I will prefer a right IJV access. This is the usual standard access as far as the vascular access is concerned. Because you're doing an urgent dialysis, you need urgent vascular access. This is easily available all the time. Creating a fistula is not possible at this point of time in an urgent dialysis, especially patients coming with an AKA. So what are the indications? Usually, as far the indications are concerned, I used to give by a mnemonic called A-E-I-O-U. It's vowels, isn't it? These are vowels not only in English. A-E-I-O-U is vowels in any language. If you take Tamil, or if you take Hindi, or if you take even any of your own native language, A-E-I-O-U is the vowel. And actually, this A-E-I-O-U is not based on letters. The vowels and consonants are based on the pronunciation. How you do it, isn't it? Pronunciation, how you're going to do it. In the sense, like, it's the way you like, give that sound. So that's what is going to tell the vowels or whether it's a consonant. So it's same for all the language. It's not only for English. So we are giving the, anyways, things apart. So this is the mnemonic for doing urgent dialysis. So one is always acidosis, which is very important to know. As far as acidosis is concerned, typically if the patient's pH is less than 7.2, plus if it is refractory to medical management, refractory to treatment, your basic medical treatment, then you can go for dialysis. Number one is acidosis. E for electrolyte disturbances. Electrolytes. When you're doing for AK as an urgent dialysis, the one electrolyte that is very important most of the times where we start dialysis is hyperkalemia. That is refractory to medical management. Refractory to treatment. Especially if the potassium is consistently more than 6.5, that is refractory to medical management, then you can start with dialysis. Not a problem. Clear? Number 2. But there are some other electrolytes also that are amenable for dialysis, like severe hypercalcemia, severe hyperphosphatemia, and severe hypermagnesemia. These are also something that are amenable to dialysis very easily. Severe hypercalcemia you can encounter in patients with multiple myeloma or osteolytic metastasis. Severe hyperphosphatemia you can encounter in patients with CKD usually, or acute phosphate. I mean, we studied acute phosphate nephropathy. We have studied on colonoscopy example sometime back. There you can see this severe hyperphosphatemia causing AK, one example, or it can be tumor lysis, or it can be anything else, or severe hypermagnesemia. Usually, whenever you hear the word magnesemia, it's almost always iatrogenic. It's due to eclampsia, where they use too much of magnesium sulfate in the presence of acute kidney injury. So, causing hypermagnesemia. It's almost always iatrogenic. So, in these situations, also dialysis is extremely helpful. But the usual scenario is hyperkalemia refractory to medical management. I stands for intoxications, which means there are a lot of drugs and toxins that can be cleared by dialysis. I'll tell you what are the drugs that you can use. Typically, the drugs that can be cleared with dialysis can be given by a mnemonic called blister, which is a common thing that's asked in exam. B stands for barbiturates, L stands for lithium, I stands for INH, S stands for salicylates, and T stands for theophylline and aminophylline. Aminophylline is a short-acting form of like theophylline only, but they are extremely amenable to dialysis. And E stands for ethylene glycol and methanol. Both are amenable to dialysis. And R stands for, sorry for that, carbamazepine. Extremely amenable to dialysis. So all these drugs are something that can be easily cleared off by dialysis. So not a problem at all. Okay. So how much you know about drugs that can be cleared by dialysis? It's also important to know that what are the drugs that are basically cannot be cleared by dialysis. So there are some drugs which cannot be cleared by dialysis. What are the drugs that cannot be cleared by dialysis basically? Suppose if somebody asks you what are the drugs that cannot be cleared, so what will be your answer? Okay, digoxin. Digoxin is basically not dialysable, but you can tell from this itself. Yeah, I mean, there are some rules to tell what are the drugs that are basically dialysable. The first rule tells you that the patient and the drug that you are planning to clear off should have a lower volume of distribution. If it's a higher volume of distribution, it would have entered so many compartments in the body, so it will not be in the blood. So if it's a lower volume of distribution, it means it's going to be typically present only in the vascular compartment. So that is number one. At the same time, number two is that this drug should have lower protein binding. And both these things tell that this drug should maximally try to stay within the vascular compartments. Then only you can do a dialysis. So that is the one thing. Apart from that, there are many other drugs which cannot be dialysed. In that, the most important is digitalis. Digoxin is the first thing they will be asking you. And majority of the other drugs, like for example, beta blockers, cannot be dialysed. Like for example, one exception is that atenolol. Atenolol can be cleared to an extent by dialysis because of its protein bind. I mean, this non-protein binding nature. But apart from that, most of the beta blockers are not dialysable. Many of the OHs, including metformin, sulfonylureas, all these things are basically not dialysable. Your diabetic drugs. If it's an overdose, you cannot dialyse them. And I think barbiturates can be dialysed, but phenytoin is something that cannot be dialysed. Carbamazepine can be dialysed, but phenytoin cannot be dialysed. Even valproate cannot be dialysed for that matter. TCAs, SSRIs, because lithium is something that can be dialysed, but TCAs and SSRIs are something that naturally cannot be dialysed to a large extent. Then apart from that, I think that's it. So these are some of the important drugs that basically cannot be dialysed. Majority of the antibiotics also cannot be dialysed. So, but nevertheless, if they ask you what is the Antidote for digitalis. The only thing that you have to answer in reality is digibind. Digibind is the only antidote that you can use for digitalis toxicity. Dialysis will not work in digitalis toxicity. Then what else? What about beta blockers? What is the antidote? If I ask you the antidote that you can use for beta blockers, what antidote you will answer for beta blockers? IM glucagon, yes, or IV glucagon. Glucagon is the antidote for beta blocker toxicity. Of course, yes. If we ask for sulfonylureas, what is the this thing, sulfonylurea toxicity antidote? Glucose, IV dextrose, because they are going to cause hypoglycemia. So this is the antidote for that. Phenytoin, you don't really have antidote. And phenytoin should be maintained in narrow therapeutic range by around 10 to 20 nanograms per ml. So beyond that, they'll cause cerebellar toxicity to a great extent. And TCA, suppose if you have TCAs, what is the antidote? Suppose they ask you TC related ventricular tachyarrhythmia. If they ask you, you're going to use soda bicarbonate. This is the best drug that you can use. Apart from that, there are some other drugs which cannot be dialysed. For example, warfarin cannot be dialysed. So of course, you know what is the antidote for warfarin? That is vitamin K. And we already discussed in cardiology in detail about how will you manage warfarin-related bleeding. We talked about that. And one more, there are two antibiotics which cannot be dialysed. One is macrolides. I told you certain antibiotics like macrolides cannot be dialysed, and even fluoroquinolones cannot be dialysed. These are drugs that cannot be dialysed basically. So what are the other things that can be dialysed? I think the only thing we can remove here is metformin. Metformin is something that can be dialysed. So just remove that. Sulfonylureas only you can write. So there are some other drugs that can be dialysed as well. For example, metformin, because metformin causes severe nephrotoxicity because it is actually excreted by the kidneys. That's why I got a little bit off structure there. So metformin is something that can be dialysed. Apart from that, there are some few antibiotics which can be dialysed. Like, for example, you have aminoglycosides which can be dialysed. I mean, you can remember the nephrotoxic drugs, which I've told you already. Then you can actually dialyse vancomycin. Vancomycin can be dialysed. And most of the beta-lactam drugs, most penicillin group of drugs can be dialysed. And even metronidazole can be dialysed. And one NOAC also can be dialysed, that is dabigatran. Dabigatran is an example of a NOAC that can be dialysed. Not only dabigatran, even edoxaban, rivaroxaban, most of the NOACs, NOACs can be dialysed. And dabigatran is the one that can be maximally dialysed among all the NOACs. In fact, majority of the NOACs can be dialysed, not a problem. So these are the list of drugs that can be dialysed and that cannot be dialysed. But in reality, these are the things that are going to ask. These blister drugs are the ones that are routinely asked. In that salicylates, theophylline, aminophylline, ethylene glycol, methanol, and lithium. So these are the drugs that they'll be regularly asking because everyone knows that lithium can be easily dialysed. Not a big deal at all. As far as O is concerned, you have overload state. Especially overload means we are talking about a volume overload here. Any patient who's having a volume overload that is refractory. Especially what I mean by a significant volume overload in reality is the fact that if the patient is having a volume overload like pulmonary edema, which is actually life-threatening, and that is not responding to diuretics. When you are using a loop diuretics, but this pulmonary edema is not responding, it's refractory pulmonary edema, not responding to loop diuretics, then that can also be cleared with dialysis because water clearance is what we are expecting here. And U stands for uremic symptoms, especially if it is severe enough. For severe uremic symptoms. Uremia is a clinical syndrome. I told you, uremia can actually cause a variety of symptoms, right from starting from if somebody asks you what are the uremic symptoms, you can write starting from non-specific symptoms like anorexia, hiccups due to uremic gastritis, nausea and vomiting again due to uremic gastritis. They can cause platelet dysfunction. They can cause bleeding, which can be very severe because the platelet function is affected here rather than the number. And apart from that, they can produce pericarditis. They can produce encephalopathy. When I say encephalopathy, it can affect both cognition as well as intracranial pressure. So mental disturbances it can cause psychiatric problems also. At the same time, it can cause peripheral neuropathy. It can cause myopathy. So much of problems are there because of uremia. So one thing that you need to know is, if they ask you in CKD patient, if they ask you the most common neurological manifestation of CKD, it is peripheral neuropathy. Most common neurological manifestation in a CKD patient is peripheral neuropathy. Apart from that, if they ask you one condition in a CKD patient which cannot be reversed by dialysis, uremic complication in CKD that cannot be basically reversed by dialysis, is myopathy. Myopathy is something that cannot be reversed by dialysis. You need to do a kidney transplantation. Then only that myopathy will resolve. As far as peripheral neuropathy is concerned, it can be partially reversed. Partially reversed with dialysis. I mean, these are the problems that happens typically in a CKD patient. But nevertheless, just I want to tell these things in the same place. So myopathy is something, it is very poorly reversed by dialysis. It's something that cannot be reversed most of the times. Peripheral neuropathy is something that can be partially reversed or partly reversed by dialysis. Majority of the other problems can be almost fully reversed by dialysis. Not a problem. So usually the urgent indications as far as the acute kidney injury is concerned is this encephalopathy, pericarditis, and this severe platelet dysfunction. These are the three things that are usually urgent in the setting of an AK, so which needs dialysis most of the times. Usually this pericarditis, why it's a problem is because this patient is having a platelet dysfunction, which itself poses a high risk of bleeding, along with the inflamed pericardium poses them at a high risk of tamponade, increased tamponade risk. So that's the reason why this becomes an urgent indication. Similarly, during dialysis, you typically, use heparin, because during dialysis, heparin use is very, very important because the blood has to enter the chamber. So, which is actually a dialysis chamber is like an external circuit where they come into the foreign material contact, they go for clotting. So, prevent that, you use heparin. But if a patient is having pericarditis, we don't really use heparin. So there is something called heparin-free dialysis that is beyond the scope of the current discussion. But usually in patients with pericarditis, try to minimize or try to avoid using heparin. We can use some alternative methods like citrate and all. That's again beyond the scope of the discussion. But it's better that we avoid heparin as much as possible if the patient is having a pericarditis, to avoid that bleeding in the pericardium and causing a tamponade risk. Clear? And we didn't talk about dabigatran, isn't it? So dabigatran, what is the antidote? I mean, can anyone tell? Because everyone is my app students only, so majority of them will be knowing. So what is the antidote for dabigatran? Just a recap. Yes, correct. Antidote is basically idarosizumab. Idarosizumab. That is the antidote for dabigatran. And you have antidotes for factor 10 inhibitors also, isn't it? What is that? Andexanet alpha. Yeah. Siraparantag is also an antidote. That's a broad spectrum antidote that works for majority of the anticoagulants. But dabigatran, idarosizumab, is a monoclonal antibody against dabigatran specifically, and you have andexanet alpha for other novel oral anticoagulants. One more drug that can be dialyzed, I think one by one it is coming. You can remember, along with phenytoin. Along with phenytoin, you can remember valproate also if you want. Valproate is also another drug that can be dialyzed to a large extent. Sorry, I'm writing in non-dialysable drugs. I can write in dialysable drugs. So I can write along with lithium, barbiturates. Along with barbiturate, you can also remember valproate. Valproate is also something that is largely dialysable. So anyways, nevertheless, so we have discussed in detail. So what are the uremic symptoms that warrants urgent dialysis? Usually it is pericarditis. It is encephalopathy next. Then probably I can go for a severe uremic bleeding due to platelet dysfunction. These are the three things that warrant urgent dialysis. So as far as the AK is concerned, these are the dialysis indications that you need to know. So vascular access in AK is usually Unless until the patient already has a fistula, usually we prefer right IJV route. That's the standard. And of course, we are going to use the indications for dialysis like AIO, acidosis, electrolytes, intoxications, overload, and uremic, like toxicity. So we know the drugs that can be dialyzed. We know the drugs that cannot be dialyzed as well. So let us move on. So what are the modalities of dialysis that is available in a patient suffering from an acute kidney injury? So basically, dialysis works by different principle. We have something called IHD, that's called intermittent hemodialysis. We have something called SLED, that's called a sustained low efficiency dialysis. We have SLED, then we have CRRT, that is called continuous renal replacement therapy. Then finally, we have the peritoneal dialysis part also. We have many different things. So all these options are available whenever a patient is suffering from an acute kidney injury and they warrant an urgent dialysis. First of all, you need to know the difference between a dialysis and an ultrafiltration. So what happens in a patient with dialysis? So in dialysis, we actually pass through the dialyser membrane. So maybe I can write, this is the dialyser membrane maybe. So these are very small membranes which are micrometer in size that is present within the dialysis box. So let us assume this is a dialyser membrane like this. There will be many membranes. Let us assume this is a dialysis that channel that is running through. Basically, what happens is like this, there will be millions of membranes will be there. So it's not like only one membrane will be there. So now the blood will be actually passing through these membranes like this. The blood will be passing through this membranes. So it will be moving through the dialyser membranes like this. And outside the dialyser membrane, in the surroundings, there will be something else that also will be flowing. This is basically the dialysate solution. This is a dialysate solution that will be actually filling the surroundings. Maybe I can draw a little with me. So this is a dialysate solution that is going outside the membrane like this. Basically, dialysis is going to work by osmosis. So there is going to be exchange of certain solutes between this region of higher concentration and region of lower concentration. Suppose if you take this one particular area and zoom it out and see, what's going to happen is very simple. Suppose if you see, this is the dialysate side, and if you see, this is the blood that is moving through the membrane. So what really happens is we set the dialysate in such a way that we wanted to alleviate the problems of patient. For example, the problem of the patient is hyperkalemia. Because of that, I'm doing an urgent dialysis. So in dialysis, in the blood, there is too much of potassium. There's too much of potassium is there. So I keep my potassium very, very less in the dialysate. So what happens is, of course, through the semipermeable membrane, this potassium moves from a region of higher concentration to a region of lower concentration till the equilibrium is balanced so that I can treat hyperkalemia. Hyperkalemia is treated now. So that's one. That is simple osmotic process. Similarly, if my main concern in the patient is uremia, so for example, if the patient is having uremia, too much of urea is there in the blood, typically dialysate will not contain any urea, zero urea, no urea at all. So that will basically push the urea molecules to the other side until it becomes equilibrium. So the urea will be reduced in the patient's blood, so thereby alleviating the uremic symptoms. Suppose if my main problem is maybe hypercalcemia. So what I do is I can keep lesser concentration of potassium here. So if the main problem is hypercalcemia, keep a lesser calcium here. So in that setting, again the things move from a region of higher concentration to a region of lower concentration. So calcium is moved towards the dialysate so that I can reduce the calcium effectively. Suppose if my problem is maybe acidosis. In acidosis, I'll be having a low bicarbonate. So I'm having only few bicarbonate, but what I do is I intentionally set higher bicarbonate in the dialysate, and that's beyond the scope again. So if it's possible, I'll tell you what are the bicarbonate concentrations in the dialysate. So higher bicarbonate means it's going to move towards the blood and your acidosis is effectively corrected. So it's a simple process. It's going to work by diffusion. That's all. So this dialysis, this is what simply we called as hemodialysis, or this is a simple principle of dialysis, which basically works by osmosis and diffusion. That's all. And this will be effective for small molecules. Small molecule movement is fine, so they'll be effective. But for middle molecules and large molecules, this is not an effective process. And at the same time, for moving water, it's not an effective process. They cannot move that much of water, even though there can be some amount of water that can move by the movement of these molecules. But overall amount of water that is extracted through this process is actually almost negligible. So that is the reason most of the times dialysis will be mixed with another entity called a hemofiltration. So this is dialysis, and we have a second technique called hemofiltration. Usually it will be done in tandem with dialysis. It usually will be doing next to next. Along with dialysis, there will be hemofiltration also going on. So what are you going to do in hemofiltration? You're going to give a positive pressure. For example, you're going to create a difference in the pressure. So like let us assume you have the same membrane-like structure. So here you have a blood, and here you have nothing. So maybe you can call it as a dialysate, but you don't have nothing here in the dialysate chamber. So if I'm going to give a difference in pressure, so for example, I make high pressure here and I make a low pressure here. Suppose if I'm going to make a high pressure here and I'm going to make a low pressure here, of course, things are going to move from a region of higher pressure to a region of lower pressure. We know that. So it's like mechanically compressing a fluid and getting an exudate done. I mean, you can remember like that. So this membrane will have pores, and we can actually set the pore size. So if you set the pore size bigger, you can even move the larger molecules. If you keep the pore size smaller, you can move the middle molecules. If you keep the pore size extremely small, you can move only water. But usually we'll set the pore size in such a way that middle molecules and water is also moving. So this type of hemofiltration technique can remove water to a substantial amount, so that this is very effective for removing water, middle molecules, and large molecules. But in patients who are having volume overload, hemofiltration is also a very important process where we need to really remove water molecules out of the system. So hemofiltration is really important. So how will you put a high pressure, how will you put a low pressure is beyond the scope. Again, if there is time, I'll discuss in some time. But nevertheless, this is how hemofiltration works. Hemofiltration, if they ask you by what principle it works by a principle of something called as convection. By something called convection is how hemofiltration is going to work. Dialysis is going to work by a principle of osmosis and diffusion. That's why dialysis is going to work. But on the other hand, hemofiltration is going to work by the principle of something called convection, where you create a difference in pressure between two areas so that the fluid, middle molecules, and large molecules also are going to move through these pores that are set in the membrane. This is how it works. So there are two techniques which you have seen. One is called hemodialysis, and second is hemofiltration. Most of the time, whenever the patient is taken for hemodialysis, even though we write as hemodialysis, many of the times hemofiltration also will be going side by side, tandem with each other. So we do basically hemodiafiltration rather than just a hemodialysis, because both these things will be done most of the times in reality. And to do a dialysis, I mean, there are many different types of dialysis. So we have IHD, we have, I told you, CRRT, we have the peritoneal dialysis, we have the, what is that, SLED, I told you. So what is the difference between all these things? In peritoneal dialysis, it's very simple. In peritoneal dialysis, the idea is quite clear. So we can do both these things in peritoneum itself, but here the fact that this semi-permeable membrane that we are using here is the peritoneum itself. The semi-permeable membrane that we are using here is peritoneum itself. It's nothing else, it's just the peritoneum. So yes, using a dialysate, you can perform this osmotic process in the peritoneum, not a problem. But how can you achieve this convection This convection is basically achieved by a variety of processes. Like for example, one way to achieve this convection is by increasing the dextrose in peritoneal dialysate. The dextrose will be too much in a peritoneal dialysate. Because the dextrose is too much in peritoneal dialysate, they'll create a strong osmolar force, and that will actually mechanically pull certain substances out. Because it's going to pull water, this water, once it's coming out, along with it, there will be a process called solvent drag. People who have already watched the hypokalemia lecture, you will be understanding what you mean by solvent drag. So what do you mean by solvent drag? Whenever water moves to a particular area, it drags certain solutes along with it, and that's what we refer to as a solvent drag. Because we are having a high level of dextrose in the peritoneal dialysate, they draw a lot of water, and once they draw a lot of water, along with it, they pull some molecules also along with that. So, and again, peritoneum has different size of pores, and they behave like an ideal semi-permeable membrane. As a biological semi-permeable membrane, you can actually clear off a lot of molecules through the peritoneum itself. So, but one additional thing that we do is, because we cannot create this pressure difference in the peritoneal membrane, so what we try to do is we add a lot of dextrose, so that you have too much of dextrose in the peritoneal dialysate. So that actually tries to create an osmotic force, pulls a lot of water, and that water is going to really result in solvent drag, and a lot of solutes also come along with that water movement. And that's what is going to happen in a peritoneal dialysis. So peritoneal dialysis and the hemodialysis differ only in one way. The membrane what you are using. If you are using extracorporeal form of dialysis and a membrane, that is hemodialysis. If you use something which is biological, the peritoneum, that is peritoneal dialysis. At the same time, the peritoneal dialysate solution will contain more dextrose compared to that of the routine hemodialysate that we are using. So this is how dialysis works in the first place. Clear? But please understand the fact, in reality, we use a RRT, that is renal replacement therapy, that we are going to use. So whether you initiate early in AK or whether you initiate late in AK has actually no mortality benefit, which means they will be asking you about if you initiate renal replacement therapy much earlier. For example, the serum creatinine starts increasing. That time itself, you start with the renal replacement therapy. Will that be beneficial? No, actually. Trials have clearly proven that there is no benefit in AK if you start renal replacement therapy early. Which means it should not be too late also, which means when the creatinine becomes 10, 15, when the patient is on the sick bed, almost going to die, that time you start dialysis, it's not going to be beneficial either. But what they're trying to tell is optimal timing is better. So there is no extra benefit that you're going to get by early initiation of renal replacement therapy. If you start dialysis, CRRT very, very early in the course of the disease, that doesn't mean you're going to get a better mortality outcome. You're going to have the same mortality outcome, even if you don't start dialysis early. The idea is very simple. Why they perform the trial, the take-home point is, if the patient needs dialysis, do dialysis. No need to anticipate and start the dialysis early. So that is the take-home point. It's not like you delay the dialysis. It's not the point. If the patient needs it, you do it. Don't start anticipating it and do it much earlier, which is not going to give any much mortality benefit. That is the take-home point, rather than getting a wrong point like thinking you can do a late dialysis as well. That's not the case. Much early initiation has no mortality benefit. You can start at optimal timing if there is indications to start the patient on dialysis. That is the idea. Okay. I think you'll be getting about this. So till now, whatever I told, do you understand? So what do you mean by dialysis? What do you mean by hemofiltration? And what are the indications of dialysis? What are the drugs that can be dialyzed? What are the drugs that cannot be dialyzed? If you understand, we can move on to the next. You want complications of dialysis. Complications is there something, because we still have not discussed on CKD in the first place, chronic kidney disease in the first place, and we have not yet completed dialysis. Who told I have completed dialysis to ask for the complications much sooner? First, let us see what is the difference between these things. So how dialysis machine really works. So usually you have inflow. So dialysis needs a very high rate of flow. So I'll be talking about the flow in some time. So first you need an inflow. So anything that comes is what we refer to as an arterial line. But I mean, it can be done from the venous. So remember, it can be done from the venous itself. I mean, for example, if you do from the IJV, there will be two ports where the blood will be taken from one port and the blood will be returned in another port. So if the blood that comes from IJV means it's a vein only, you cannot talk that the blood is coming from IJV, so it should be called venous. But in the dialysis perspective, the blood that is moving away from the body is always an arterial blood. That the blood that is moving towards the body will always be like a venous blood. For example, it's like blood that is moving from the renal artery and going back into the renal vein, the purified blood that is coming out of the kidney. It's like that. So even though the blood is coming from the vein, this line will be called as an arterial line only. Even though if you have cannulated in the IJV also, the blood that is coming out of the patient will be basically the arterial blood only. I mean, it's like arterial blood. So it's like an arterial line. That's called as an arterial line. And usually there will be a pump. And if you see a pump, that one pump will be there that will be rotating here and there in the dialysis circuit. And if you have really seen on dialysis machine, you will be understanding that this pump is something that rotates like this. So why it rotates is, while it's rotating on either direction like this, while it is moving towards that side, it will create a negative pressure. Negative pressure in the arterial side. So that's what it's trying to create. This blood pump is basically creating a, we can call this as a pump. This pump is basically creating a negative pressure in the arterial line. So why it's creating a negative pressure? Because sometimes you might be having a vein. You're doing a dialysis from a vein. This vein may not be having high flow at all. This vein might be having a very poor flow. In fact, veins don't produce that much of pressure. And that much amount of flow may not be enough to perform the dialysis. So only if you create a negative pressure, there will be continuous movement of blood out of the body. And this pump, after moving, it will create a positive pressure. Because it moves that side, they'll create a positive pressure on the other side. Because this positive pressure is needed to create the process called convection. We know that. This positive pressure is needed to create, I told you beforehand itself, you need a positive pressure to produce this convection process. So again, for the movement of the blood forward, you need that positive pressure into the dialysis circuit. So once it moves, it enters the dialyzer. This is basically the dialyzer I'm talking about. The blood will be moving with the positive pressure into the dialyzer. And once it comes out of the dialyzer, there will be a lot of other purification systems that will be there. For example, one important thing that the blood passes through is something called as a bubble foam. Bubble foam. This bubble foam is very important because it removes any entrapped air. Because if you slowly start producing small air drops, and that is going in, I mean, that is, if it's unchecked, means the patient slowly starts getting air embolism. So you need to have a bubble foam that actually traps the air that is present in the blood, any air that is present in the blood. And this blood will be now returned to the patient. Returned to the patient through a line called as a venous line. Even though both blood is, both blood taken from the patient is also venous and pushed into the patient is also venous. But in the dialysis terms, the blood that is taken is from the arterial line and pushed towards the venous line. This is what we refer to as a venous line. This is a simple process that happens. So in the dialyzer, ultimately, you know that what's going to happen. There is one more entity that you need to know. There is effluent will be there. Effluent will be coming out in the dialysis. So I told you very clearly. So there is something called dialysate that is flowing in the opposite direction. We know that. So if the blood is moving in this direction, dialysate is flowing in the opposite direction. So why is that so? Suppose, can anyone tell if the blood is moving in this direction, the dialysate will move in the opposite direction? Why? Why is that so? Don't tell, it is to stimulate the countercurrent mechanism in the kidney. I mean, there's also one reason why there is a countercurrent mechanism in the kidney, but why is that so? Why you have blood flow in one direction and dialysate that is flowing in the opposite direction? Yes, of course. That is to wash out only. Suppose this for example, let us take this is the dialysate that is performing the exchanging function, and this dialysate now will become ugly, isn't it? It will not have any much, gradient to maintain that movement of the solute. So this has to be moved out continuously so that there will be replacement of fresh dialysate. Fresh dialysate should keep moving inside so that, as Ankit told, to maintain the gradient. So, and to keep washing out the waste products. That's really, really important. That's pretty important as well. So that's why we have this dialysis in the first place. I mean, that dialysate that is moving in the opposite direction. That is to maintain the gradient and to keep washing out the waste materials. Ugly dialysate should keep moving out. Then only you can maintain the gradient. So which means from the dialyser, you will get the dialysate that is called as an effluent, which is also referred to as ultrafiltrate. And of course, and this is a simple HD process. This is how a hemodialysis works, where the main things are the arterial line, venous line, pump, which creates a negative pressure on the arterial side and positive pressure in the blood that moves towards the dialyser. And this dialyser, from this dialyser, you're going to get an effluent. That is what we refer to as an ultrafiltrate. And after that, it moves towards a bubble foam, which removes air. And then the blood will be sent back into the patient through the venous line. So clear? And I can actually set some, a lot of things can be adjusted within the dialyser and the and the dialysate, so that I can precisely know what kind of concentration of a particular solute I wanted in the blood. So I can change the composition of the dialyser. I can change the ultrafiltrate, which means how slowly or how fast I need to do everything I can change. But only one thing that you need to know is there is another entity called CRRT, that is continuous renal replacement therapy. So here, because I'm removing ultrafiltrate, actually I'm reducing the volume of the patient. At the same time, I'm removing a blood with a high negative pressure so that the flow rates into the dialyzer will be very high. So this is hemodialysis. The flow rates will be extremely high. And at the same time, I'm removing a lot of volume from the patient, thereby making the patient a little hypovolemic. And this is not desirable. Suppose I'm receiving too much of flow and I'm actually reducing the patient's overall volume in the body. This is actually not desirable. In a patient who is hemodynamically unstable and the patient who is in shock, this is basically not desirable. This is something I don't want really. So that is why we got the concept of continuous renal replacement therapy, where I can do for 24 hours, CRRT. So what I'm going to do in CRRT is very simple. I'm going to cut down this flow to a large extent, because if I can operate at this negative pressure and make that negative pressure very less, or if I don't create any pressure at all, and I'm leaving it to the nature, how much ever blood that flows, let it flow. Or I can set a particular very small negative pressure so that I don't want that much flow. I can remove very little blood from the patient. At the same time, to prevent this loss of volume that is happening through the ultrafiltrate, if after the dialyzer, I can replace that ultrafiltrate equally, hand on hand, if I replace that ultrafiltrate with a replacement solution. I can replace that ultrafiltrate with a replacement solution. How much I need to replace? Again, it depends. For example, what is the hemodynamic stability that you want? If the patient is in severe shock, I'll replace equal, or even I can replace more also if I want to increase the BP. If the patient is having okay BP, maintaining the inotropes, patient is volume overload, bloated, I can remove a little bit. Mildly I can remove, but still I can replace to prevent that BP from falling. So if you add this, this is the basic principle of a CRRT. If you use those things, this is called continuous renal replacement therapy, where my flow into the dialyzer will be a little less. At the same time, whatever ultrafiltrate I'm removing, accordingly I can give some replacement solution back. So at this replacement solution, once again, it depends. And I can adjust all these things. Everything I can adjust, basically. After this dialyzer, if I give replacement solution, I can know how much ultrafiltrate I'm removing, what is the dialyzer composition, and what is the amount of solutes I'm taking, and accordingly, how much I have to replace back. So everything, if I can calculate, and that is why we have a dialysis technician also. They can do all those things very easily. And if I give a replacement solution back, my BP will also be maintained. So my hemodynamically unstable patient who's having a shock, usually my choice of renal replacement therapy will be CRRT only. Do you get what I'm trying to tell here? Maybe I can show an image if you want. Do you understand? Okay. Maybe image might be fine. Let 1 second. We can use an image there. So I think this must be easy to understand. So you can see the arterial line here, and you can see the blood pump that creates a negative pressure because the blood has to be drawn. And then after this, it creates a positive pressure so that the blood enters the dialyzer. So once the blood enters the dialyzer, there might be some air bubble. To remove that air bubble, I'm going to use a bubble foam here and a venous heart trap. And once this blood is removed of bubbles, then I can give a positive pressure once again, because it will be positive pressure only. So once I give a positive pressure, it goes back into the patient. So this is a simple mechanism of a dialyzer. Create a negative pressure while drawing and put a positive pressure while pushing into the patient. And then only it can go into the patient. And in between, the dialyzer is present, which is going to purify the blood. What is not shown here is the ultrafiltrate that is produced. That is not shown. At the same time, in CRRT, you can additionally give a replacement solution also if you want. If you give a replacement solution, you can actually maintain the blood pressure as well, because whatever you are removing, you are replacing here means. So why the patient should have further hemodynamic instability? The patient will not develop any further hemodynamic instability. This is the concept of CRRT. Do you understand this? Now at least? I mean, it's a little complicated, but nevertheless, I think I tried to tell as simple as possible. Do you understand? Yes, but we need to know a lot of calculations. That's different. We don't want that, but I mean, you have a separate books on dialysis, so I don't want to go into details. I think this much must be more than enough for basic understanding and even for your exams also. So let us see what is the difference between a probable hemodialysis and you're doing something called a CRRT. That's called continuous renal replacement therapy, and probably you're going for SLED. I mean, before that, I can write SLED. What do you mean by sustained low efficiency dialysis? That's called SLED. And then you have the CRRT, continuous renal replacement therapy, and finally you have peritoneal dialysis, PD. So as far as the solute removal is concerned, IHD removes solute very nicely. SLED also removes solute very nicely. CRRT also removes solute very nicely. PD is very poor in solute removal. So in acute situations like severe hyperkalemia and all, PD is a very poor option. In very high, very severe uremic symptoms, patient is about to die, I don't think PD is a viable option. And at the same time, HD is something that can be performed within 4 hours. Most of the time, for example, the duration, the time taken to complete the dialysis, it's just 4 hours. And as far as SLED is concerned, you will be taking around 6 to 12 hours. Even some institutes do for almost 16 hours. CRRT is something that is done 24/7, 24 hours. And PD is something that is also done 24 hours. Typical. And as far as the hemodynamic stability is concerned, so HD is this something that is associated with the worst hemodynamic stability, which means it's not going to have a good hemodynamic stability, and the patient can go for severe hypotension. That's why it's not very good for patients who are hemodynamically unstable already. SLED, it's fair. Hemodynamic stability is fair. And CRRT, you have a very good hemodynamic stability. And overall, if you want the hemodynamic stability, the best is the peritoneal dialysis only. So it is not associated with hemodynamic instability at all. It is something it's going to go separately. So no problem at all. It's not going to have any vascular access in the first place. It's happening through the peritoneum. So because there is no vascular access, it is associated with the best hemodynamic stability, to be honest. And as far the cost is concerned, IHD is going to be a little bit less costly. PED also less costly, but a little bit more from the expenditure point of view. And as far as this SLED and CRRT is concerned, the cost is going to be very high, which means the equipment that it needs is complicated. Equipment and the expertise you need equipment is actually simple in case of PDN, your routine intermittent hemodialysis, but for SLED is also a little simple, but for CRRT you need a little complex equipment, more complicated equipment here. Technically speaking, IHD is actually quite complex, technically demanding procedure, hemodialysis, and SLED is also technically more complex. You need to calculate a lot of stuff. CRRT is a little bit simple, and peritoneal dialysis is also more simple. Technically, it is concerned. It's quite simple. And as far as complications are concerned, IHD, the most important complication is hypotension. Here, the most important complication SLED is again hypotension, even though it's better compared to intermittent hemodialysis. Still, BP drop is a very potential complication. So here in CRRT, the most important complication is air embolism, because it's happening for 24 hours continuously with the vascular access, and there is a more chance of bleeding because it needs continuous heparin. 24 hours, the blood should be mixed with heparin. So basically, this has more risk of bleeding compared to the routine IHD or SLED, because 24/7 the blood will be mixed with heparin in the dialyzer. Whereas peritoneal dialysis is concerned, you can get peritoneal infection, which is quite common, and hyperglycemia, because the peritoneal dialysis by default contains extremely high sugars. They can go for severe hyperglycemia, and you can go for viscous trauma, visceral trauma. Visceral trauma in the sense, sometimes while putting the peritoneal catheter, you might injure the bowel without your knowledge. So these are some of the important complications that you're going to face with the peritoneal dialysis. These are the basic difference between SLED, HD, CRRT versus PD. But whenever patient is unstable, in exam, that is the final take-home point. Whenever the patient is unstable, always go for CRRT. This is the preferred modality in ICUs. If CRRT is not available, then you can go for SLED, which can be done with your routine equipment itself, but you're doing it a little slow. That's all. It's like same hemodialysis only, but instead of doing it in 4 hours, you're doing it in 6 to 12 hours. You're doing a little slowly. That's what we call it as a sustained low efficiency dialysis, SLED. So CRRT there, go for that. The patient is hemodynamically unstable. If CRRT not there in ICU, then SLED may be another option. But IHD is never an option for patients who are hemodynamically unstable, because that will worsen the hemodynamic stability and the patient will die because of severe shock in that scenario. PD is not an option for AKA most of the time, because in AKA most of the times you take for dialysis because there is some urgent indication, and PD is extremely poor in solute removal, even though it has the best hemodynamic stability, but it's associated with very poor solute removal. Maybe it could be used for patients who are having chronic kidney disease and you want to do a dialysis, then PD must be fine. But in acute kidney injury, usually PD is not a very, very good option. Unless and until you don't have any of these things and you want to do a dialysis, then PD at last you can consider, but I don't think PD is a very viable option in urgent scenarios where you want to remove the solutes. And we will be discussing about dialysis more later on. I think this must be more than enough. Do you understand this? Understood? Cool. Okay. So fairly okay. But what is their exam point? Their exam point here is this only. These indications for dialysis and the drugs that can be dialyzed, that drugs cannot be dialyzed, and CRRT for hemodynamically unstable patients. So this will be the question. So apart from that, I don't think other things will be a usual question in exam. Now I think now the discussion on AK is absolutely complete. Now we need to move on to the CKD, chronic kidney disease, CKD patient. As far as CKD is concerned, usually what is the difference between AK and CKD? That's what you need to know. So what is the difference between acute kidney injury? What is the difference between AK versus CKD? So most of the times, AK patients, I mean, there is a huge differences there. AK patients, the injury happens over days to months. Sorry, hours to days. Hours to days. Whereas in CKD, the injury is going to happen over months. So by definition, how much time you need to tell the patient is having a chronic kidney disease? By definition. The question is for the audience. How much time you need to tell that the patient is having a chronic kidney disease? Yes, many of you have answered. It is basically 3 months. Beyond 3 months is where we are going to tell that the patient is probably having chronic kidney disease. 3 months. 3 months is the key here. Okay. So what is the definition of CKD, by the way? We have discussed on the definition of AK, but as far as the definition of CKD is concerned, we are going to tell sustained decline in the EGFR, because here the EGFR is very, very important. So if the EGFR is decreased to less than 60 mLs per minute per 1.73 meter square body surface area, and it's sustained for more than 3 months. So this is the basic definition of CKD. Or if there is any albuminuria, any amount of albuminuria that is happening, and it's there for almost 3 months or more. Which is sustained for more than 3 months, or any proteinuria for that matter. If it's persisting for more than or equal to 3 months, or number 3, or any structural problem in the kidney that is there for at least 3 months. So this is the basic definition as far as CKD is concerned, which means EGFR decline less than 60 for more than 3 months, or albuminuria persisting for more than 3 months. All these things will be the basic definitions of chronic kidney disease. Usually in acute kidney injury, the patients very likely will be oliguric, even though patients can be non-oliguric at times. But more importantly, in a patient who's having a chronic kidney disease, patients will be basically non-oliguric. Patients usually will not be oliguric. You know the definitions of oliguria. And what are the conditions? Now you are going to have a test probably. I can ask what are the conditions till now we have learned that produces non-oliguric AK. What are the conditions that produce non-oliguric AK? We have discussed that already. Okay, acute interstitial nephritis. Then aminoglycosides. Okay. Contrasting nephropathy, correct. CIN. Then one more thing you can tell is post-transplant acute rejection. No, sepsis will have oliguria only most of the times. Post-transplant acute rejection, especially acute cellular rejection. Post-transplant acute rejection is some other condition which will have a non-oliguric renal failure, which means anything that affects only the interstitium or only the tubules without causing any substantial damage to the tubules by blocking it. So minimal damage to tubules, more damage to the interstitium, usually will be non-oliguric. They will not be oliguric. If they have substantial damage to the tubules or the glomerulus, they're going to produce oliguria only. So acute interstitial nephritis, aminoglycoside induced, majority of the toxins, not only aminoglycosides, majority of the toxin related renal injury, including myoglobin or hemoglobin. So majority of the toxin related injuries, especially aminoglycosides, then acute interstitial nephritis, or you have a contrast-induced nephropathy. It's also a toxin, right? So maybe post-transplant acute rejection. So these are the conditions typically tends to be non-oliguric in nature. Most of the times in AK, in ultrasound, you will have usually a normal kidney size. But here you may have a small kidneys. Not always, but may have small kidneys. We have discussed in detail about that, which are the conditions which produce a CKD with normal or even enlarged size kidneys. So may have a normal kidneys. And eGFR will be dynamic here. And serum creatinine also will be more dynamic. It means it will not stay in a particular area. It's going to keep changing, fluctuating here and there. But here it will be more stable. GFR and creatinine will be more stable. So some differences if you want. So between acute kidney injury versus chronic kidney injury. So usually in CKD, patients will be non-oliguric. But you have some other problems that are typical of CKD, but that does not differentiate, like anemia of CKD, then bone problem, bone disorder, that is called as CKD mineral bone disorder. So many problems that are peculiar to CKD may be there, but that does not really tell whether the patient is having AK or CKD. Many patients with AK also may have anemia. So this is not very important, but still you can know just for the exam sake. So in that, you remember usually CKD patients will be non-oliguric. That is very important because till now people believe that CKD patients will be oliguric. I don't know why, but it's very simple that CKD patients generally will be non-oliguric in that perspective. Suppose if I ask the etiology of CKD, what is the most common cause of CKD in the world? What is the most common reason for developing a CKD? Yes, diabetes, diabetic kidney disease. DKD is the usual reason for developing a CKD. Then you have hypertension. That's called a hypertensive kidney disease. That is called hypertensive nephrosclerosis. Diabetes is typically around 30 to 40%. Hypertensive nephrosclerosis is basically approximately around 20 to 30%. Then chronic glomerular nephritis is a very important cause, 10 to 20% approximately. It includes both primary as well as secondary glomerular nephritis. And you have chronic tubular interstitial disorder, chronic tubular interstitial nephritis, which contributes to approximately around 8 to 10%, but typically less than 10%. Then you have polycystic kidney disease, especially ADPKD, which contributes to less than 5%. And obstructive uropathy, chronic obstructive uropathy. I can write about vesicular reflex here, which is common in children, so which can contribute to less than 5% again. And you have ischemic nephropathies like renal artery stenosis, fibromuscular dysplasia, which can contribute to less than 5% again. So the top most on the list is always the diabetic kidney disease. I'll talk about diabetic kidney disease in some time, but nevertheless, you need to know the staging of CKD. How will you stage the CKD? How will you classify CKD? So staging of CKD is based on two things. One is called eGFR, and at the same time, you need albuminuria. Based on albuminuria is also, you can basically stage the CKD. But for our routine understanding, it's just eGFR that's going to be the exam question. Staging is also based on albumin, but albumin is more of a risk of progression of CKD rather than just a staging process. But eGFR alone is enough to stage the CKD, chronic kidney disease. You have stage 1 CKD, then you have stage 2 CKD, then you have stage 3 CKD, then you have stage 4 CKD, then you have stage 5 CKD. As far as stage 1 CKD is concerned, your eGFR will be more than 90, which is a normal GFR. Normal GFR is somewhere around 90 to 120, which means in stage 1 CKD, you'll have a normal GFR, which means patient will have only risk factors in this situation. Only risk factors for developing CKD, like patients may be having a diabetes, patients may be having a hypertension, patients may be having some problem which can cause CKD, but patient as such is not having a CKD in fact. So this is number one. So here, the most important treatment. So what you need to do if the patient is having a risk factor, you have to optimize the risk factors. You have to reduce the risk of developing a full-blown CKD. Optimize risk factors like control diabetes, control hypertension. If there is patient having cardiovascular condition, control the cardiovascular problem. So that's what you're going to do. Stage 2 is something where you're going to have a GFR of 60 to 89. So 60 to 89, here the patient is at risk of developing a CKD. Still, they have not developed CKD. They're only having at risk, but the GFR is in the range of 60 to 89. So where here the idea will be to estimate progression. There are a lot of algorithms where you can estimate progression based on the patient's current clinical status. And third is where you have GFR of 30 to 59. So as far as 30 to 59 is concerned, this patient has developed a CKD already, which means we call it as an early CKD. As I told you, any GFR less than 60 that is persisting for more than 3 months is CKD. So patient has already developed a CKD, it's an early CKD. So here the most important thing to do is evaluate and treat complications. Assess for any complications, which we'll be discussing in some time, and start treating that complications. 3 is basically divided into 2. One is called a 3A, where the GFR is in the range of 45 to 59. And we have 3B, where the GFR is in the range of 30 to 44. 30 to 44 is 3B. So in stage 4, the GFR will be only 15 to 29. So this is a late CKD. This is no longer early. There's a late CKD. In this patient, my ideal thing will be preparation for renal replacement therapy. Preparation for RRT, because this patient will be needing a maintenance hemodialysis in short period of time. So preparation for RRT may include counseling of the patient towards the further worse outcome that they're going to face. At the same time, I can start creating AV fistulas, because only at this time, if I create maybe over a period of time, once they end up with CKD, their fistulas will be ready so that I can start with maintenance dialysis. So I have to prepare the patient. So that is the most important here. If the GFR is less than 15, eGFR is less than 15, this is what we refer to as an ESRD, that is end-stage renal disease. In this particular patient, it's better to start with dialysis. This is not an urgent dialysis, this is a maintenance dialysis I need to start with. And also preparation for transplant. If patient has indications, if indications are there, if indicated and potential candidate, then I can prepare for transplant. But remember, any GFR less than 15, you can start with maintenance dialysis. There is many controversies regarding this. I don't want to talk about that, because some people tell that GFR itself, they'll give different guidelines. For example, if they ask you indications for dialysis, number 1, based on the GFR, diabetes plus eGFR less than 15, or a non-diabetic plus eGFR less than 10. So this is what the cutoff that's given in many textbooks. But in general, there are so many controversies, because some nephrologists tell less than 5 you can wait. If the patient does not have any compelling indication, you can wait, because patient is still non-oliguric and not having any complications. Why you want to start with dialysis? Unnecessary. But to keep a full stop for all these controversies, there is one landmark trial that came in 2012, which showed that early initiation of dialysis in patients with ESRD have a better mortality benefit compared to patients who have been initiated late. So it's clear that whenever the patient becomes eGFR less than 15, it's better to start with dialysis. That's the current idea. You have to prepare and start the dialysis. But apart from that, you can start in this late patients also, because early CKD patients usually will not have that severe complication. Usually they will have complications that will respond to your routine medical management. But if there is patients who's having a late CKD, but having refractory complications like severe refractory anemia, severe refractory acidosis, severe refractory volume overload, severe refractory electrolyte disturbances, bone problems, then even in late CKD, you can start with maintenance dialysis. It's very simple. The indication for dialysis in CKD is either you go for end-stage renal disease or refractory complications. Second indication, refractory complications due to CKD. So in both these settings, it's better to start with hemodialysis. Like I told you, for liver, the best treatment for any CKD-related complication is transplant only. That is the best treatment. There's no doubt about that. You have to replace the dysfunctional kidneys. So then only you can get some relief out of that. Otherwise, you are not going to get, for sure. So, but in our routine setting, it's not possible to do a transplant tomorrow. So in that setting, I can go for a dialysis. So any refractory complication due to CKD or patients who's having a ESRD, these are the two classic indications for starting with maintenance hemodialysis. Maintenance hemodialysis itself is a big thing, which I'll be discussing in some time. But apart from that, there are some problems that you can get due to uremia, which I told you. Some uremic complications. So they can get a lot of variety of constitutional symptoms because of uremia. As I told you, they can get anorexia, they can get malaise, they can get nausea and vomiting, and there is something called a uremic fetor, bad breath, because of uremia, and they will have something called a dysgeusia, and everyone knows what you mean by dysgeusia. That is altered taste. Very commonly, they will experience something called as a metallic taste because of severe uremia, and they can go for hypothermia. Often, the hypothermia is a very common problem in patients with CKD. And second, some skin complications are there. As far as the dermatologic complications are concerned, they can develop pruritus, very, very common, and xerosis, dry skin. And majority of the patients may go for something called a uremic frost. Uremic frost. So this is due to actually urea that is coming out of the skin and becoming some crystal-like deposition. That's white crystals. Usually they will form white crystals on the skin. That's called as uremic frost. So in exam, whenever you get a question like patient with CKD coming with a white crystal on the skin, that is basically uremic frost. Very common thing that you see in real practice. And they can go for some deadly complications like calciphylaxis. Calciphylaxis is a deadly complication. CKD is one of the important risk factors. I think I didn't discuss. Calciphylaxis is something due to calcification of an end arterial vessel that supplies the skin. It supplies some part of the skin. That vessel will go for calcification and complete occlusion. Because of that, they'll go for necrosis of that area. Necrosis of that area. And this is a very poor prognostic state because this necrosis area can go for rapid infection, severe sepsis, and it has a very high mortality. Like 60 to 80% mortality is there, usually seen in end-stage CKD patients. There are a lot of conditions which produce calciphylaxis. One is CKD itself is associated with calciphylaxis. Then many conditions that produces hypercalcemia and hyperphosphatemia can produce hypercalcemia, hyperphosphatemia can produce this kind of calciphylaxis, and warfarin is associated with a higher risk of calciphylaxis, especially CKD patients. Those on warfarin has an extremely high risk of developing calciphylaxis because warfarin itself can induce skin necrosis. So high risk is there with warfarin. Whenever the patient is using warfarin and getting calciphylaxis or getting warfarin-induced skin necrosis, the first step is to stop warfarin, and next step is to reverse the effects of warfarin by giving vitamin K. That's very important. You have to reduce the INR very fast. That's what is going to happen. Suppose if you want to know calciphylaxis, I'll show you some images. This is one of our patient with CKD who went for calciphylaxis. This is a very early stage. We detected that and we treated. And if you don't treat it, this is what is going to happen. This is a typical image that you will get in exam. So let me put here. So this is a very early stage. So this patient was on warfarin basically, and a CKD patient as well, where you can see, there is something that is happening here. So that's a very early stage. If you think about something else and you leave this, it will progress towards something like this. This is a local area of complete necrosis of the skin. And this is a very important image in exams as well. This is typical calciphylaxis that you get because of CKD patients. That's the second skin problem that you get because of CKD. And apart from that, you can get some neurological issues also. Neurological, they can go for encephalopathy. Uremic encephalopathy typically comes with reduced cognitive function, reduced cognition. This can manifest as altered mental status. This reduced cognition can manifest as reduced attention span, reduced memory. All these things can happen in these patients. Apart from that, they can also get, we didn't talk about seizures. They can get seizures. They can get neuropathy, especially peripheral neuropathy, which will be of axonal type of peripheral neuropathy. And most often, if they ask you the most common neurological complication of CKD patient, answer is peripheral neuropathy, which is the most common neurological complication. And sleep patterns may be changing. Patient may be sleeping more in the morning, less in the night, so they can have insomnia, reduced sleep. And one important other problem is restless leg syndrome. Whenever in exam they ask about restless leg syndrome, three things you need to know. One is pregnancy, second is anemia, and third is CKD. So these are the three causes usually in exam they expect about restless leg syndrome. The treatment of choice for restless leg syndrome is ropinirole. Pregnancy, anemia, CKD. So restless leg syndrome. Then coming to the cardiovascular problems, as far as the cardiovascular problems are concerned, this patient may get pericarditis, which is also quite dangerous because associated with bleeding, I told you there is high risk of tamponade, and they will have accelerated atherosclerosis because of endothelial injury, accelerated atherosclerosis. And if anyone asks you what is the most common cause of death in a patient with CKD, what is your answer? Most common cause of death in a patient with CKD. Yes, of course, it's cardiovascular death. So if anyone asks you the cause of death in patients with CKD, one second. If anyone is going to ask you what is the common cause of death in a patient with CKD, due to at any stage, whether on dialysis or whether not on dialysis, it's always cardiovascular death. Because of vascular atherosclerosis, there is a higher risk of developing myocardial infarction. So this is the most common cause of death. I mean, in the sense like not only myocardial infarction, it's always about other cardiovascular conditions. Sorry, I think the load is too much. Some cardiovascular problem. It's not just MI. This cardiovascular problem is the most common cause of death in patients with CKD at any stage, on dialysis, not on dialysis. Does not matter. That's the most common cause of death. It could be ADPKD. It could be due to tubular interstitial disease. It could be due to diabetes. It could be due to anything. It is the most common cause of death, and they can cause LVH, severe strain on the ventricle because of uremia itself, and many patients will have secondary hypertension because of that severe strain causing LVH. They can go for cardiomyopathy over a period of time, and finally they can end up with congestive heart failure also. So many reasons are there which can cause problems in CKD. You can get hematological complications with CKD. Hematological complications. The most important hematological problem is anemia of chronic kidney disease. Very important. And this anemia has a multifold reason. It's not like just it's due to the low erythropoietin. Low erythropoietin is just one cause of this anemia. It's actually multifactorial. Iron deficiency anemia can also be there, which means iron deficiency also can be there. There are multiple reasons why this patient should get iron deficiency. For example, this patient will get uremic gastritis, and because of that, small bleeding may be there. And bleeding is also quite common in these patients because of platelet dysfunction. Bleeding is an important reason for developing iron deficiency. At the same time, these patients may have reduced iron absorption from the GIT because of inflammation and high hepcidin levels, which blocks the iron absorption from the GIT. At the same time, this patient can also lose blood in the dialyzer circuit. In the dialysis circuit, this patient can lose blood 1 or 2 ml every time they go for dialysis. So that could also be the reason for iron deficiency. So multiple reasons are there. Third important reason is the bone marrow fibrosis that these patients are going to get. That is due to severe hyperparathyroidism. Many of the CKD patients will have severe secondary hyperparathyroidism. High levels of parathyroid hormone can result in bone marrow fibrosis, and that can cause anemia in this individual. So anemia is multifactorial, and it's just not due to low erythropoietin deficiency. If somebody asks you which of the disorders we talked about, I told you about certain disorders that cause CKD. Among this, which is going to have a higher risk, maximum anemia of CKD, which is going to have a maximum anemia of chronic kidney disease? I told you so many causes, isn't it? You have these many causes. So which is going to have a maximum anemia of CKD? Chronic glomerulonephritis. No, actually. It is this one. Chronic tubular interstitial nephritis. This is the one that is having maximum risk of severe anemia. Severe anemia. Why? Because of the loss of erythropoietin, that is maximum in tubular interstitial disorders. Who is actually producing erythropoietin? We take who is producing erythropoietin. These are the peritubular, especially near the proximal convoluted tubule. You have certain peritubular fibroblast-like cells in the interstitium. These are peritubular fibroblast-like cells, which are basically producing erythropoietin. And there are some extraglomerular mesangial cells, also referred to as something called Lassus cells. These also produce erythropoietin to some extent. So many conditions. I mean, so many things are. So out of so many conditions that we see, this chronic tubular interstitial nephritis is the one that affects the interstitium very prominently, and that is the reason why you'll have a maximum erythropoietin deficiency there. Because of that, you're going to get a maximum anemia there. So that is chronic tubular interstitial nephritis or chronic tubular interstitial disease. Apart from anemia, you can get bleeding, as I told you. Bleeding is multifold in uremia. Usually, bleeding is due to platelet dysfunction. Platelet dysfunction. And it will be more severe also sometimes, because this dysfunctional platelets produce more bleeding than actual decline in the platelets. That's when ITP, even though you have a platelet of less than 10,000 or 15,000, you don't get that much severe bleeding. But in uremia, you might get severe bleeding because even the platelets are 1 lakh or 1.5 lakh, these are dysfunctional, they're not functioning properly. And number 6 is metabolic complications. What are the metabolic complications that you're going to get? You can get hyperkalemia, and you will be getting high ANGAP metabolic acidosis. That is HAGMA. Remember, in early CKD, you can get an AGMA, but as the CKD progresses, you will get a high ANGAP metabolic acidosis only. HAGMA. These two are very, very important. And apart from that, you can get hypocalcemia, hyperphosphatemia, hyperphosphatemia. And you will get, because of the hypocalcemia, you will get severe hyperparathyroidism. This is basically a secondary hyperparathyroidism, or sometimes patients may even go for something called tertiary hyperparathyroidism, which I'll be discussing in some time. And because of all these metabolic problems like hypocalcemia, hyperphosphatemia, and hyperparathyroidism, patient will go for some kind of bone disorder called CKD-MBD. That's called the CKD mineral bone disorder. CKD-MBD, CKD mineral bone disorder. This is what is going to happen. So these are the complications as far as CKD is concerned. Now discussing about this calciphylaxis in detail. So this calciphylaxis, otherwise also referred to as something called a calcific uremic arteriopathy or arteriolopathy. This is called calcific uremic arteriopathy. This is the other name for calciphylaxis. So the pathophysiology of calciphylaxis is just the calcification of the small to medium vessels that typically supply the skin and subcutaneous fat. That is the classic calcification. That is the pathophysiology. Once this small to medium vessels go for calcification, they go for severe ischemia. That severe ischemia will result in skin necrosis, and it will be associated with extreme pain. So painful necrotic lesions due to calcification of small to medium vessels that supply the skin and the subcutaneous fat is what we refer to as a calciphylaxis or a calcific uremic arteriopathy. As far as the risk factors are concerned, CKD is a risk factor, but ESRD is the basic risk factor more than the other stages of CKD. The end stage renal disease has more risk factors. Diabetes mellitus is a risk factor. People who are using warfarin, as I told you, is a risk factor. And patients who are already having thrombophilias like APLA syndrome or SLE is a risk factor. And people who are having hypercalcemia, as I told you, and hyperphosphatemia are at risk factor. Especially more importantly, they will tell something called a calcium phosphate product. So if that is elevated, is a high risk, which means patient might have a hypocalcemia, but a very significant hyperphosphatemia. So if you couple that, you have a high calcium phosphate product, despite the fact that there are hypocalcemia, but if there is significant hyperphosphatemia, that also increases the risk of developing calciphylaxis. So calcium phosphate product is more important as such than your actual calcium levels and phosphate levels. And apart from that, severe obesity is a risk factor. Compared to males, females are at more risk factors. And at the same time, if there is significant local trauma, or a repeated local trauma, it's again a risk factor. Clear? Diagnosis is mostly clinical, but just by looking at it and seeing the risk factors, you can make a diagnosis. Biopsy is rarely needed. Even though biopsy is gold standard, but biopsy is rarely needed. You don't really need the biopsy. As far as treatment is concerned, there are few treatment options that is there. So the first treatment is surgical debridement. But it should be very careful. Sometimes it can push the infections into the bloodstream. So surgical debridement and wound care is very important. Along with that, there is something that works that's called sodium thiosulfate. Sodium thiosulfate is something that can work to a great extent. At the same time, transiently, you have to stop warfarin, vitamin D, calcium. So these are the things that you have to stop right now. So if you really want to use warfarin, because patient has some compelling indication like atrial fibrillation on warfarin, you need to use warfarin means you can start using NOACs instead of warfarin. Shift to NOACs. If the patient has a compelling indication to start warfarin, try to shift to novel oral anticoagulants. But try to avoid vitamin D and calcium, because I told you this calcium phosphate product is basically a risk factor for developing calciphylaxis. So vitamin D and calcium will increase the calcium phosphate product and actually increase the risk of development of, progression of calciphylaxis more and more. So you have to stop all vitamin D and calcium supplements the patient is getting as of now. And you have to reduce the risk factors. Other risk factors like management of ESRD by doing regular dialysis, and management of hyperparathyroidism by giving certain therapies like reducing the phosphate by giving sevelamer or some phosphate binders, which we'll be discussing subsequently. So managing hyperparathyroidism, managing ESRD is also very, very important. But in exam, usually the one thing that they'll be asking is sodium thiosulfate, which can be useful in patients with calciphylaxis, which is showing better benefit compared to others. As far as ESRD and calciphylaxis is concerned, there is almost 60 to 80% mortality. That's why I told you it's having an extremely high mortality risk in any patient with end-stage renal disease getting a calciphylaxis or calcific uremic arteriopathy. You are going to have an approximately 60 to 80% mortality, which is very important, and that's humongous. And don't forget this picture, which is very important for exams. Very commonly, you will get this kind of picture in ESRD patient of those on warfarin. If the patient is only on warfarin, not a ESRD patient, go for warfarin-induced skin necrosis. If the patient is having ESRD, irrespective of whether they use warfarin or not, in that condition, you go for a diagnosis of calciphylaxis, that is calcific uremic arteriopathy. And even vitamin K, not only warfarin, even vitamin K deficiency is basically a risk factor for developing calciphylaxis. I think that must be it for the day. Tomorrow I'll start and continue from where we left. I think in the first session of tomorrow, we should be able to complete the kidney. And after that, I'll be starting with hepatology, maybe with the liver. Liver is more important because gastro, there is too much overlap with surgery. So we'll be doing with the liver. Maybe there are only important topics in gastro we'll be doing. I think today's session is useful and informative. So many points are there. This is actually a power pack session once again. So it must be beneficial for you. Tomorrow, can we do start early? Depending on my online appointments, because it's an impromptu class, I didn't really plan for the class. I just suddenly thought like, okay, 5 days I'm free. So after the surgery, I recovered like a couple of days back. So I thought I'll start with the session. So I do have some online consultations in the morning. So I'll try to do it. I'll try to tell, but I'll intimate you. Maybe stay tuned in the Telegram group and in the WhatsApp group. So before starting, definitely I'll intimate, like at least half an hour or 1 hour before. No need to worry about that. So tomorrow, I think I have only 7 appointments, which starts by 10 o'clock. So I think I should be able to complete. But the problem is I have 2 international appointments. That's the problem tomorrow. In that sense, that generally takes a little bit of time. So maybe tomorrow I can start by 11:30, 12 maybe. If suppose the patients go fast. Otherwise, it takes time. Okay. Thank you. Let us start with the session tomorrow, and hopefully this was a very useful session. And it's a very power pack session. Whatever I told you are really, really important. And go back to the MCQ book and start putting the MCQs. You'll understand how much you have learned today. Thank you very much. Good night.